Welcome back to session 2. This session is a presentation on new energy modalities, burn, freeze, or shock, which is best and when. I'm again joined by Katerina Bishalia and Claire Martin, and I'm delighted to introduce our speaker, Dr. Atul Verma. Atul, over to you.
Thank you so much, Jason, and thanks to Rhythm Interventions Online for inviting me to give this talk. And today I'm going to be talking about a number of different energy sources, burn, shock, or freeze, which is ultimately the best. These are my disclosures. So I think with respect to burning, we just talked about a case presentation of more traditional RF parameters, but of course, the biggest change in RF recently has been the so-called high power, short duration RF technology. And I think if we think back to biophysics, it's important to remember that open irrigation at a high rate was not necessarily designed just to remove clot or char. It was actually designed to allow us to use power-controlled ablation to go deeper into the tissue. The problem is that in thinner areas of the atrium, particularly around the esophagus, we don't want lesions that start mid-myocardially and go epicardially. We would rather have more surface-oriented endocardial lesions. And so lowering the irrigation rate can actually help that. Furthermore, in terms of what determines a lesion, it's typically the temperature at the interface with the tissue and not necessarily just power and an arbitrary duration. And so the use of embedded thermocouples right at the tip of the catheter, as well as materials to allow for rapid heat dissipation, have been critical to this so-called technology. A couple of the technologies that have gone down this path are, for example, the diamond tip catheter system, where the diamonds actually result in far quicker dissipation of heat from the tip compared to standard platinum iridium materials. Typically, you're using 50 watts delivered for 6 to 10 seconds, and the power is modulated to a target temperature of 50 to 60 degrees Celsius with embedded thermocouples right on the tip of the catheter. This is some data not using the diamond tip, but the so-called Q-dot system, where we can see that high power, short duration lesions result in shallower lesions, but wider lesions, which may be more what we want in the left atrium, particularly on the posterior wall and other thinner areas, to improve contiguity, but also to potentially reduce the complications of collateral damage. From the diamond tip perspective, there was a randomized study using the diamond tip catheter system versus a control sort of tacticath type ablation system. And these patients were all followed up for a year. And what was very interesting is that by using power modulated, temperature controlled ablation, there was actually a reduction in procedure time, whether it was total ablation duration, RF time, or LA dwell time, compared to a purely contact force guided mechanism. And furthermore, the absence of contact force did not seem to alter the results in any way, because operators were able to target a tissue temperature, which became a very powerful surrogate for contact force. Or maybe I should say it the other way, contact force is but a surrogate for tissue temperature. In terms of some preclinical data where we actually specifically looked at the impact of contact force on high power, short duration lesions, it was very interesting because the only determinant of lesion size was actually the duration of ablation, and whether we applied 5 grams, 10 grams, or 30 grams of contact force really had absolutely no impact on the lesion depth when you're using a temperature-controlled, power-modulated system. I'm now going to move to so-called shocks and pulse field ablation, which obviously is the new kid on the block. People are very excited about it. And essentially, it combines a magnitude of an electrical field with the duration of electrical field exposure to create a so-called electrical field intensity, which then determines cellular death. The modern principle of irreversible electroporation is basically, and why we now have it today and we didn't have it 20 years ago, is because 20 years ago we had defibrillators which could deliver a very large charge. But with progress in technology, we can break this large charge into a series of much smaller pulses which can be delivered in packets or trains, which give you the cumulative effect of the large charge, but doesn't cause the patient to jump off the table or the other thermal damage that may be associated with a large charge. So if we look at the anatomy of pulses, we can see that we can use either a monophasic or biphasic type of pulse wave. And then again, we can deliver them in multiple packets. In general, most of the systems are using biphasic waveforms as opposed to monophasic waveforms, because as it turns out, you can use lower powers with biphasic pulses, because compared to monophasic pulses, the biphasic can give you much less muscle stimulation, the same amount of cell death as a monophasic pulse, but as a lower power. So it's a way of being able to optimize delivery without getting the problems of a so-called large charge. Now, there are many ways that you could adjust pulse fields in order to get the optimal pulse field ablation. And I'm not going to go into each of these different buttons or knobs that you can adjust. However, this is a science in and of itself and very, very fascinating, quite frankly. In general, there are many approaches that are being used out there, but the typical parameters for most PFA systems are a voltage of about 500 to 2000 volts, biphasic more so than monophasic. The pulse width is generally a few hundred nanoseconds to about 200 microseconds on the outside duration, 10 to 30 pulses per packet, and generally 1 to 6 packets being delivered. As we know, PFA has some of the advantages of potentially having so-called tissue selectivity, or more accurately, certain tissues are more resistant to the effects of pulse fields. And so phrenic nerves and other myelinated nerves, for example, are very difficult to damage permanently with pulse field ablation. Furthermore, compared to RF ablation, the esophageal tissue doesn't undergo permanent damage with PFA and allows itself to very rapidly regenerate over hours to days. And then finally, the likelihood of pulmonary vein stenosis seems much less likely with pulse field ablation compared with radiofrequency ablation. So what do we still need to discover with PFA? Well, there's no doubt that PFA is the future and we are all moving there, and I'm very excited about it, quite frankly, on the safety side of things. However, we do still need to optimize lesion depths beyond 3 or 4 millimeters. I think this is coming, but we need to understand how to get deeper lesions with PFA. And finally, we need to understand how this works. Like, why is it that myocardial cells are so sensitive to PFA, and how exactly does this work on a basic science level? These are still topics that need to be answered. Deeper lesions are, however, coming, and this is a preview of the Galaxy medical system, where they have been able to get lesions as deep as 7 to 9 millimeters. I'm going to skip over this section in the interest of time, but what I do want to say is that repetitive applications seem to be very important to maximizing the depth of PFA lesions. So in other words, applying fields just once may give you a stunning effect and you may lose your electrograms, but if you actually want to get a truly transmural lesion, repetitive applications seem to be key. Finally, I'm going to talk about the new generation of freezing tools with ultra-low temperature cryoablation, and in contrast to traditional cryoablation, here we're talking about temperatures of minus 196 degrees Celsius, as opposed to minus 80 degrees Celsius, is what you would find with a normal cryo balloon. In this case, the Adagio medical system has an 11 centimeter long catheter, which you can mold into different shapes depending on where in the atrium you want to ablate. And generally speaking, you can use either a 60-second freeze with at least a 30-second thaw and another 60-second freeze for very deep lesions. And in areas like the posterior wall, you may decrease it to a 30-second freeze followed by a thaw and another 30-second freeze. In early human work that is being done by Tom Potter and other investigators in Europe, it seems like transmurality with this energy source is not an issue, because they have been getting very, very high freedom from atrial fibrillation success rates that are in the range of about 80 to 85%. And certainly in my own experience with this technology, transmurality seems to be excellent. Safety outcomes also seem to be very, very good. Phrenic nerve palsy, since they have introduced cryomapping, seems to be very, very low risk. We do have to use an esophageal warming balloon given the very low temperatures that we create. And ideally, it would be nice if we could prevent any damage to the esophagus without a warming balloon. And so in the future, we may notice that we combine energy sources. And this is some work that I'm doing on the combination of ultra-low temperature cryoablation plus PFA, where basically we introduce about 30 seconds of ultra-low cryoablation and follow that with PFA stimulation. And when we compare these modalities of PFA alone to PFCA, which combines it with cryo, we see that we have similar abatement of the lesions. We have, however, fewer microbubbles being produced by the PFA. We have less skeletal muscle contraction. And in terms of tissue depth, we are seeing a trend towards more transmurality and higher tissue depth with the combined modality. So with that, I just want to conclude that high power short duration may be well suited to the LA, but may not be well suited for deeper lesions unless we change the modalities and the times with which we are delivering these energies. PFA is also limited by lesion depth, but research is evolving. Ultra-low temperature cryoablation can get past the problem of lesion depth, but we still need esophageal and phrenic protection, and maybe combined energy sources is where we need to go in the future. Thank you very much.
Thank you so much, Atul, for such a wonderful presentation. It's kind of a great partner to that first session, looking at the local impedance and then moving into the others. I just want to remind the audience that, again, we are live, so please submit your questions online and we'll try and address that to the panel. We have about 9 minutes left for discussion within this session before we take a break. So I guess Atul, from your perspective, realizing that we're kind of on the threshold of this new horizon where, for probably about 10 years, there was very little change. And then all of a sudden now we're revisiting temperature-controlled ablation, impedance-based lesion analysis has kind of come back into the forefront. And then we have new technologies in terms of the ultra-low cryo and the pulse field ablation. You mentioned the idea of combining energy sources, which is an interesting concept. Do you think that the combination of PFA and RF is likely to overcome some of this lesion depth issue, or like you mentioned with the cryo and PFA, or do you think that PFA modifications to the formula are likely to give us that depth that we can move it to other chambers besides the thin-walled left atria?
Yeah, that's a great question, Jason. I think it's a little bit of a race. I certainly do see a future where PFA is going to be able to give us the type of tissue depths that we would need for working, let's say, in the ventricle. Would the combination of RF plus PF be a useful combination? It really depends on the details of RF, because if we think about our discussions this morning about RF and impedance drop and lesions of about 2 to 4 millimeters, and even if we think about the limitations of RF in the ventricle, where we know that we can't always get as deep as we want to, and that's why we have to go epicardial and do other things in the ventricle, I'm not sure that the combination of RF-PF is going to be a long-term win. I think where ultra-low cryo in combination with PF is useful is because ultra-low cryo certainly can give us the tissue depths. We're right now using an ultra-low cryo ablation catheter in the ventricle, and we can go as deep as 15 millimeters if we want, which of course is completely transmural even in the ventricle. And then, it's a matter of dialing back the cryo so that you minimize the chance of collateral damage, but also take advantage of the ice impedance changes in the tissue to be able to deliver better PFA.
Thanks. So, Claire, of the technologies that we just heard in the presentation, and I think we're all excited about the possibilities of PFA. What are your thoughts on sort of the diamond temp catheter? Do you have any experience with that?
So I don't yet have experience with it, but I am about to start using it for VT. The reason I haven't used it so far is that we don't use the Abbott mapping system, which it's mostly being used in conjunction with so far. But I'm planning on using it in conjunction with the Rhythmia mapping system. And I am very interested to see how that is going to help in terms of giving me more effective lesions in the ventricle. I think that's something that has been a recurring theme both in this talk and in previous talks, is how to get those deeper lesions within the ventricle. That does require some different sort of technological considerations to some of the modalities we've said. But I think that the diamond temp catheter certainly has the physics behind it in order to try and get those deeper lesions. So I think does hold quite a lot of promise for creating more effective lesions in the ventricle.
Thanks. Just looking through, sorry, go on, Katerina.
Sorry, can I ask something? I was impressed by your presentation, Yuta, and I was asking, you gave me so many glimpses into the future. I've never had the chance to see the PFA. You were talking to me about the ultra low temperature now. So if, I'm considering now, for example, a patient who is referred for, an AFib ablation, which is the patient who deserve what? De novo PVI, would you use high power short duration? Are you foreseen to use pulse field? Would you go for massive technologies like the one you showed us?
Yeah, that's a very good question. So I've had the privilege of using the sort of so-called high power, short duration diamond temp or Q dot catheters, the PFA catheters and the ultra low cryo catheters. And I think this is still a moving target, to be honest. There's no doubt that PFA is fast, it's efficient, and it's safe. And so I think there is justified excitement about PFA. Um, I have to admit, though, I've been very impressed with the clinical results of ultra-low cryo. Normally, I'm always very skeptical and I don't report success rates that are very high. I always expect that some of my patients, when I'm using a new technology, are going to fail. But you know, in the first 11 or so patients that I did with ultra low cryo, I've now had a chance to follow them out for several months post ablation, and I'm just not seeing recurrences. Again, you know, I think transmurality is definitely being achieved, but we have to use an esophageal warming balloon, and we have to be careful of the phrenic nerve. Um, you know, is RF going to continue to play a role in 3 or 5 years from now? I don't really know, because PFA now can be delivered point by point, just like RF. PFA can be modulated. PFA can be combined with other energy sources. So I'm not sure if RF as a standalone modality is going to continue to exist into the future. And here I'm talking more like 5, 6 years down the road.
Can I ask something to Atul? I was just, so for me, the purpose of a kind of first time PVI is to make the procedure as kind of straightforward and quick and as standard as possible. So I was really interested in what you were saying about the good outcome results from ultra low cryo, but are you concerned that the possible kind of complications and the necessity of having the warming esophageal probe and things, is that just making it too complicated? Like, if we're just wanting to isolate the veins, don't we want something that is as kind of as quick and as straightforward as possible? And do you think maybe PFA has some advantages over the ultra low cryo in that regard?
Yeah, I think, Claire, you make a good point. I think you know, PFA is simple. It's easy. It's pretty standardizable. You can do point by point, or you can do single shot type devices. You know, the ultra low cryo, I would say the biggest added complexity is really just the esophageal warming balloon. It probably takes a little bit longer, although again, the catheter is designed as a sort of single shot for the pulmonary vein. So if you just want to do pulmonary vein isolation, it can be quite efficient. We are using it more in the persistent AF population, where we think about doing other things other than PVI. So you're right. You know, if you want to treat 10 paroxysmals in a day 5 years from now and just line them all up and get PFA done, you probably can do that. And then maybe with the redos, we need to think about other things.
Thanks, Atul. So I'm afraid that's all the time we have for this session. I just want to thank you again for such a wonderful presentation, and to Katarina and Claire for their insightful comments. We still have a lot to come on day 3 of Rio 2021. We'll take a short break from the main program, but starting next, we have a symposium, and I want to remind you that the training village is open, so please check that out. A little later today, session 3 with Dr. Richard Schilling will be a case session of subcutaneous ICD implantation with conscious sedation with Lucas Boersma, and a great panel. So please stay with us.